All right. Well, hi, everybody. This is Shanelle Van Dyke. I want to welcome you to the Patient Safety Culture Survey Quality Improvement Series that we just started kicking off last month. We had a call on March 23rd where we talked about handoffs and transitions, and specifically we brought up the SBAR tool, and I provided some resources along with some little quick videos. As the SBAR tool has actually been proven in many case studies to actually impact and improve the handoff and transition domain within the Patient Safety Culture Survey. So today, as a follow-up, we are going to be, I'm just going to recap on like a slide or two what was talked about on the 23rd for those of you who weren't able to attend. And then I'm actually going to hand it over today to Emily. She is the Med-Surg Manager at Pal Valley. I'm going to let her introduce herself when we get to her slides. And she's going to just be providing some information about how they use SBAR, how it's been implemented, how it's helped their communication, and scenarios in which they use it. So with that being said, I'm going to get started. So for those of you who are probably familiar with SBAR, I just wanted to include this slide. It stands for Situation, Background, Assessment, and Recommendation. And it's actually a communication tool that provides a method of clearly communicating pertinent information from like a clinical encounter. It helps to empower all of the members of the healthcare team to provide their input into the patient situation, including recommendations. So assessment and recommendation phases provide an opportunity for discussion among the healthcare members, the members of the healthcare team. So, you know, in some of the facilities where we've actually implemented this, it can be a little nerve-wracking at first and not everybody is comfortable, but it's a great means of having one standardized tool or a standard means for communication. Let's see here. So with that being said, Emily, I'm going to let you kick off and start sharing about your SBAR experience. And if you want to give a little introduction of yourself, it would be much appreciated.
Okay. Good morning, everybody. This is Emily. I am currently the manager of Med-Surg and ICU here at Pal Valley Healthcare. I've been here almost 8 months. I came from a 250-bed facility in Farmington, New Mexico. They were a Six Sigma organization, and SBAR was their preferred method of communication. And so when I got here, there wasn't really a good way to distribute information amongst our staff to let them know of changes and that kind of thing. And so I kind of brought the SBAR with me. The first project that we did with it was we had recognized that our patient identification bands weren't really as productive as we wanted them to be, and so we were going to revise those. And so we did it at our entire patient directors leadership meeting and distributed it, and so all the same departments were on the same page and knew when it was going to take in effect and all of that kind of thing. So from there, it's been my key communication tool with communicating with any of my staff about anything that's going on. The example that I've provided for today is we recently decided that we could have an isolation safety zone where our staff didn't have to get gown and gloved, that they were just going in to speak to the patient really quick. And so because that was a new thing, we decided to do an SBAR. And so it just kind of gives the staff an idea of what's going on, what brought us to the point that we're at, what we looked at and how we could revise it, and then what we were going to do about it. And there's been some months where I put out 6 SBARs. There's been some months where I put out 2. There's been 15. You know, it just depends on how much change we're going through or things that I feel that my staff needs to be educated about. We did an employee satisfaction survey in December, and it got really good feedback that communication had improved considerably. Staff felt like they were more in the loop, and it was just generally overall well received.
Emily, this is Shanelle. Would you like me to go to the next slide that has that template?
Absolutely.
Okay. All right.
So on this one, like I was talking about the isolation safety zone, so the situation was that sometimes they just want to peek in, see if they're sleeping, see if they're comfortable, just ask them a quick question. And, you know, in the past they'd had to put on a gown and gloves, so that was the background. So our infection control, as the assessment, looked into what was best practice, what other facilities were doing, that kind of thing, and they discovered that there's really like a 3-foot entry into the room that really doesn't put anybody at high risk of being contaminated. And so she decided that and recommended that on April 1st you could now walk into the room as far as the open edge of the door and not have to gown and glove. But if you had to go farther than that, you had to gown and glove. And so we put this out on April 1st. I always attach a staff signature page to it so that, one, I know that they've read it, and two, if they violate policy or whatever down the road, I'm like, well, you said you read and understood this. And so it's just provided both accountability and a good source of information. The next slide is just what the blank one looks like. I mean, it's really easy to make in Word or whatever your preferred is. And I just go in. I only put them out on the first of each month so that staff aren't overwhelmed. They have the whole month to read them. And then at the end of the month, if I've noticed that there's some staff that haven't read them yet, I send them a little email and say, hey, you forgot to read this. It's important for care. Go ahead and you still have a chance.
That's awesome. And for those of you on the line, before the call, I had sent out an email that actually attached both copies of the template on these slides. One that was filled out with the information on the isolation safety zone, and then the other one was a blank template that Emily had shared that she utilizes. Let's see here. So does anybody, just with that being said, before we kind of dive in and I start asking Emily some questions, does anybody on the line have any specific questions right now for Emily? Don't forget, if you muted your lines, you need to unmute them. We have a quiet group today. So, Emily, a couple questions that I have is, with you bringing the SBAR tool to Cal Valley from your previous hospital, is it just something that's used within your unit, or is it something that's used hospital-wide that other units have or departments have kind of taken on as well as a means for communication?
I know of about 3 other departments that are using it as well, but it hasn't become like a facility-wide like requirement yet. I could see it coming because the requests just keep getting more and more as they see how it works and that kind of thing.
Gotcha. So have you, and this might be a little bit of a tougher question, have you received any kickback or fighting? I shouldn't say fighting, that's a terrible word. Just any kickback from some staff that are just any barriers you've run into with using SBAR in terms of getting everybody to use it, or some saying that it's not necessarily an effective tool or anything like that? Have you run into any barriers, and if so, how have you overcome them?
The only kickback that I've ever had was the month that I put out 13 of them, and they were like, holy crap. But other than that, it's really well received everywhere.
That's awesome. So to make sure I understand, so not only do you use it to communicate with the staff, but your staff in your department use it when communicating with others, such as shift handoffs and stuff like that. It's not just, like you mentioned, it's everything within your department on every level, correct?
The ER and us use it for report. Our nurses fill out an SBAR with their patient information, and that SBAR pretty much follows the patient through their stay here, and then they just adjust applicable information things that change, like their IV fell out and they had to put a new one in, so they changed that. But for the most part, it's the same SBAR that follows the patient through their entire stay.
That's wonderful. So out of the whole SBAR experience and everything, is there one particular situation where you guys have used SBAR that you could share with us that was just something, maybe like an error could have occurred, or something, for lack of a better word, bad could have possibly happened if you guys weren't using SBAR? Is there any stories of that nature that you could share with us?
Not that I can think of off the top of my head. I think there have been, like my wristband example, I think that if it hadn't gone facility-wide, there would be a lot of confusion and all of that. But otherwise, I can't think of any big incidences that it's really helped prevent, other than just a lack of confusion and not knowing stuff.
Okay. So before I move on, because we with these PSC quality improvement series that we're doing, we try to just keep them really short and simple and to the point, so that we can get people back to their day, and so there's not like a competing with webinar overload. But I guess my main question for you would be, if for a facility who isn't necessarily using a communication method right now, such as SBAR, or who is possibly thinking about implementing SBAR, do you have any words of wisdom or selling points that you would share with them as to why you think they should use SBAR, or why you think SBAR is so great? Other than, of course, the examples and everything you've shared. But
I think that SBAR is just really simple to understand, and your staff tend to have more of a buy-in for process changes or what have you if they kind of understand where it's coming from, what we've done to see what's going on, and then how we've tied all of that together. So SBAR just really has a very simple layout, and in a world of medicine where there are so many different formats for communication and that kind of thing, I think it's the most logical, and how it explains it, and just kind of goes through the process of change. And nursing specifically is a very process-oriented profession, and so I think that once a facility decides to use something, especially SBAR, that it needs to become the only way of communication, because then everybody's on the same page.
Thank you for that. I appreciate you sharing today. I really do. So, hey, if Sarah's on the line, I may pick on her for a second as well with Pal Valley. Sarah, I know we recently worked with you in your hospital to do that patient safety culture survey in December. You were one of the additional facilities that joined on. Just hearing today's presentation, and then the one that we had on the 23rd as well about SBAR, do you think in order to kind of spread the great communication that Emily has been doing with her staff in her department, do you think that maybe that might be something that you guys are going to be looking at, like maybe facility-wide, to do to help improve your patient safety culture survey scores for handoffs and transitions domain?
Absolutely. We've talked about it actually, even maybe that Emily's not aware of in different venues. Even our business office is using that same process to communicate with her staff. And then we've also tried to push it to our long-term care. So when we're having that important handoff to our long-term care residents into the emergency room, that they are using that same sort of communication. So I think that would be a huge asset as we're rolling our patient safety culture out and that survey information. I think it would help a lot.
Well, as this wraps up, I may pick on your facility again towards the end as we wrap up the Flex Grant year, which I believe is August for everybody who's on the call. From now until August, like every 2 weeks, we're going to have a short little 20 to 30-minute topic-specific webinar on each domain, where we're going to do one on the first topic, like we did, just using these two as an example, we on the 23rd had a tool that we shared about how to improve a specific domain in the patient safety culture. And then today, as a follow-up, we will be, recruiting a facility to share how they're using that tool and their feedback on how it's working in their facility and so on. So we're going to be doing them every 2 weeks. I'm going to send out a flyer today, if not by tomorrow, that includes the rest of the schedule from here till the end of August. And so the last couple ones in August, I'm thinking we may just do a short little 10-minute spot for a handful of facilities to share how they have been doing with their improvement. So if it's something that Pell Valley is going to be working on, we may bug you again in August to share how that's been coming along. So just FYI, I'm going to harass you guys.
Okay.
Well, with that being said, does anybody on the line have any questions for Emily and Sarah at Pell Valley? We got a quiet group today. Good thing I'm a chatty Kathy. So I'm just going to go over the next couple slides, and then everybody can be dismissed and get back to their day. So a couple of things that I just wanted to bring up is some reasons as to why you should be using SBAR. Emily was kind enough to share why they're using it in their facility and how she's brought it from other positions that she's worked in. But overall, in some of the hospitals here and also in your state, there are so many reasons and effective ways to use SBAR to help reduce the barrier to effective communication across different levels of staff, different departments. It creates a shared mental model around all patient handoffs and situations. Not necessarily just all of those, as simple as just doing a handoff to something, a critical patient, but also it's just a means for critical exchange of information. It's a memory prompt for you, and it's so easy to remember, and it encourages effective communication and a standardized means of communication for staff and departments facility-wide to communicate. And it helps reduce the incidence of miscommunications, where some of the videos that I shared last week, the little short, 1-minute videos that I shared, it provided a demonstration of an unfortunate event that had harm on the patient, where it gave a scenario where there was ineffective communication, and then it gave a scenario, the same scenario with effective communication using SBAR to prevent the patient harm incident. Those I'm going to read as a follow-up to today's webinar and the one in end of March. I will be sending out all the tools and materials again, just so you guys have them all in one spot. It will include the March 23rd presentation along with the links and the videos and the templates and tools used from IHI. And then just some brief ideas of when you could use SBAR. If you're trying to, one thing that I would like to encourage is that if this is new and it's not something you're using in your facility, but you guys want to start adapting it, obviously start small. Start with just one department, see how it goes, and then do like a PDSA to see how it's coming along. And make sure that you work out all the kinks before maybe spreading it into another department and so on until maybe eventually it becomes like the standard mean of communication within your hospital, or at least the unit that you feel that it would be the most necessary in. As Sarah mentioned, they're even talking about using it in the business office, which is amazing. This is just a slide that I stole from the last presentation. It's just another synopsis of how SBAR will help. There are some other tools, so if by any means, if a facility on the call today has tried SBAR and it wasn't necessarily, didn't work for you, feel free to reach out to me and we can maybe try and troubleshoot a different communication tool. There are a couple more that are nationally recognized from like the Joint Commission. But again, SBAR seems to be the go-to tool. We can, if it's something that you feel like tackling in your facility to help improve your patient safety culture, handoff, and transitions domain, we can work with you hands-on to help you with that implementation and that process. Whether it's myself, Rochelle, and Kyle, or it's us helping put you in connection with a facility that is experiencing similar issues that may have overcome those. On the screen now are the links for the tools and resources shared in today's presentation and the one that was back on March 23rd. They're all hyperlinks, but again, I'm going to attach all these tools in the email as well, just in case some of the hyperlinks don't work or if you have run into any problems. There we go. Today's call, like I said, is being recorded, so when the recording becomes available, hopefully tomorrow, if not by Monday, you'll have an email with the recording and all of this information. On the screen, you will see my contact information as well as Kyle Cameron's, who is the Wyoming Flex Coordinator. And then we also have Rochelle Benarci's contact information, who helps with MBQuip and QHI. So for those of you who are on today's call, I will let you have the last 8 minutes to get back to your day. We'll wrap up early, and feel free to reach out to me if you have any questions about today's presentation. Oh, one other thing is I included Emily's contact information in the slides. She was kind enough to say, hey, yes, if any of the facilities have questions and want to reach out to me directly about more hands-on SBAR and what we're doing and how I've done it, then please feel free to use Emily's contact information. She will be a great resource. So with that being said, thank you for joining today's call, and have a great rest of the day, everybody.